Good morning. Thank you. It's a great honor to be presenting at this podium with this esteemed audience. I'm very impressed to see this many people in person. We just had a neurosurgical meeting last week, and it was packed as well. So it's impressive that our abstaining for in-person meetings created so much interest and travel. And the opportunity to see each of you and hug you and shake your hand and talk with a close proximity, I think it's impressive. So it's even more honorable to present this lecture today because I think as we return to normal, we should talk about our future, we should talk about where we stand, to understand each other a little better. The topic, we'll talk about this a little bit more, but in general, to be part of this distinguished lecture series is, thank you, you know, you can't describe this honor. So I'm very much impressed of society choosing me for this, and you know, I'll try to stand up to your expectations. But I must say that I really have not known Dr. Prithviraj very well. I met him several times, but he was so big of a star when I was starting my career that there was no opportunity for him to get closer. Dr. Rax, on the other hand, became a friend over the years. We both came here to the United States from Eastern Europe. He was from Hungary, I'm from Soviet Union. And so we remained friends till now, and I hope to see him soon and wish him well, because both of them did so much for our field, advancing us from where we started to where we are now. And I think it just makes sense for us to continue this tradition to have distinguished lectures in their honor. So these are my disclosures. I work pretty much with every company. I try not to discriminate, but this is just for the next few months because as I become president of our society, I have to have no conflicts, which is kind of hard these days. But I try to teach and research and advise the companies of what to do right. So I don't feel very conflicted when you work with everybody. I think it's worse when you work with one company and then you become biased. But I'm very biased towards the neuromodulation and towards society work in general. I'm president-elect of INS, and I'm sure most of you are members of Neuromodulation Society. And I'm vice president of World Society of Stereotactic Functional Neurosurgery, which is a great honor in our field. I was president of American Society of Stereotactic Functional Neurosurgery, and we were able to move society to the higher level. But I think success of ASIP is very impressive, and I hope we can emulate this with all our society we're working. I want to bring your attention to this, in the corner, it's called Cancer Pain Research Consortium. It's something that is really not well known, but it's a group of enthusiasts who are trying to bring more awareness to the cancer pain in general. So if you want to participate in this, that would be wonderful. The surgery for pain, the way it is today, is something that is built on a major foundation. And when we talk about what's happening in 2022, it's important to understand where we started. Because going back to 1967, that was a very interesting year. I wasn't born yet, but a lot of things changed that time. Because the year started in neurosurgical field, I'm a neurosurgeon, so it's a little bit near and dear to me, from publication of this paper. There was a young resident, just graduated from a residency program, who came with this concept that you can treat the trigeminal neuralgia by microvascular decompression. Very heretic idea, because before that, the nerve was cut through different ways, mechanically, electrically, chemically. And then somebody said, you don't have to cut the nerve. You can decompress it, and the pain will go away. So now it's known as Geneta procedure. You've heard of it, you've seen it, you've seen patients with that. But it came out in 1967 because he put together a symposium and was published in our professional journal. And it was at the end of January. But in the beginning of January of 1967, this paper came out. And this paper on temporary abolition of pain in man was essentially dealing with confirmation of recently published gate control theory of pain. So gate control theory of pain that came out in 1965 was a theoretical concept that you can control the pain by flooding interneurons with non-painful information. Very interesting theoretical concept, but how do you prove this? So the paper came out 2 years later in 1967, essentially showing that these researchers, Wall and Sweet, investigate on themselves. So they implanted electrodes into infraorbital foramen of each other, turned the stimulation on, and during this time of stimulation, they did not feel pain in the area of infraorbital nerve distribution. Now, we don't support self-experimentation, so please don't do this. But they used this experience before all the IRBs were invented, before they went to treat the patients. So wonderful concept, don't do it at home, but something that kind of moved the field forward, because we now started to understand how things are working and why we can control pain without cutting the nerves. And just to kind of coincidentally, to illustrate this further, this happened. In paper came out about electrical inhibition of pain by stimulation of dorsal column, something that we know now as a spinal cord stimulation. And it was almost exactly 55 years ago, because it was in March of 1967 when the paper came out. Once again, fresh graduate from Case Western, moved to rural Wisconsin, had a patient with a cancer pain, kind of hopeless situation, implanted him with electrode. Pain went away completely. Patient died 2 days later, but the experience has occurred. It was published, and it revolutionized the field. And ever since that time, we've been using it, and the field has been growing, and I think this talk was pretty much about this. So 55 years of pain neuromodulation for this new modern concept of how to manage pain, these things changed tremendously. So just think about it. Norman Shealy, completely unknown, recent graduate from training, comes to a new place, implants patient with stimulation, controls the pain, and the field is changing rapidly. But what he had to work with was very primitive. He had a tiny device that had a single electrode that would be placed directly on the spinal cord, was not percutaneously inserted, was not a wire, was just a paddle attached directly to the cord itself, with a ground stuck in the paraspinal muscles, with a receiver, and that's kind of illustrated here. So that's what we had back then. Now, why are we talking about 60 years of neuromodulation? This happened in 1967. Well, it turns out that they were not the first. The first actual clinical use of neuromodulation happened exactly 60 years ago in 1962 in California. The neurosurgeons, they were innovators of the day. They were the same people who invented very interesting PS shunts, Pudens Schulte. So Schulte was co-author here, and Pudens was a chair. And Hunter Sheldon was this innovating neurosurgeon who decided to treat facial pain with implanted electrical device. So they actually wrapped electrode around branch of trigeminal nerve. And interestingly enough, out of 3 patients, in 2 of them, pain went away just from wrapping the electrode. But one of them was turned on, and the pain went away, and the frequencies they were using is right here. It's 14,000 hertz. So high-frequency stimulation, the modern invention, was known back then. And this was actual birth of neuromodulation, we know it now. So this was first clinical use of neuromodulation for pain, and that's why we're celebrating 60 years this year, because it's a huge change that revolutionized the field, and not just for us, but for millions of patients worldwide. So what has changed, and where we're standing now, and where we're going to be heading? So it's very interesting to overview this, because looking from where we are now, a lot of things appear very strange in terms of hardware, procedures, indications, and all that. But just like this, a few years from now, what we're doing today will look strange. So we should be prepared for this. And knowing history, hopefully, will help us to understand the future. So hardware is not just an empty term. There's a lot of different devices that we use routinely, and it's important to see where we were and where we're now. Now, some of you may remember this, but these are receivers from 2 different companies that were used for chronic neuromodulation. Now, we don't implant them anymore, but every now and then you see the patient who has it, and we explant them because they outlive themselves. And it's very interesting that there are different companies coming up with different ideas how to deliver electricity to the human body. These receivers were replaced by implantable pulse generator when I started my journey. So this was something that I've tried in the beginning. I've used these receivers, and I pretty much abandoned them because it wasn't comfortable for the patient. They couldn't take a shower, they couldn't swim, there was always an issue with skin irritation and so forth. So the implantable pulse generator was a huge step forward. So implantable pulse generators progressed over time as well. The first one had 4 contacts, then the next generation had 8 contacts. And please ignore the brand names. It's just here for illustration because some of you may remember them as we were using them. But 8 contacts became 16 contacts. So suddenly you could use 2 8-contact electrodes. You can use 4 4-contact electrodes connected to a single device. This allowed us to widen the area of coverage. This allowed us to avoid placing multiple systems in the same patient. And the next step was to make these devices rechargeable. because I remember patients coming every year to have battery change, and that was cost prohibitive, and that was traumatic, and the risk of complications was higher with every generator replacement, and therefore it was a blessing to see the devices that can be recharged. Very revolutionary concept, kind of shooting yourself in the foot, eliminating number of surgeries that you were doing for replacement, but it was good for the patients, and we took it. Interestingly enough, thanks to competition, we saw tremendous technological spurt, and suddenly we see not just many devices, but we see smaller devices. So you have miniaturized rechargeable devices, which were much more pleasant for the patient because they had this big hockey puck things implanted in them, and suddenly it was much smaller. The 16 contacts became 32 contacts. So now you can have 2 16-contact electrodes, 4 8-contact electrodes plugged into a single device. So you have much more diversity in the options you're offering to the patient with pretty much advancing your technology. The standard approach became adaptive. So now you can actually change the stimulation paradigm based on the patient's positioning, on the level of activity. Now, it's not being used all the time, but it exists. And for some patients, it makes tremendous difference because instead of changing the programming, they can just pre-program it in advance. And whenever activity or position changes, suddenly the paradigm and the parameters adjust themselves. The MRI compatibility became a major game changer for us because for the first 20 years of me using neuromodulation, it was a dogma, you should say. You know, it's just like when you have a pacemaker. Once you have the device, you should not be getting MRI because these devices are not MRI compatible. They're metal. How can they be MRI compatible? And that was normal. So everybody who would need an MRI will go for myelogram instead. And then suddenly we realized we can make these devices conditionally approved for MRI because as long as it's done within certain settings, it suddenly became safe. So non-MRI compatible devices, you know, they're a thing of the past. Everything is MRI compatible now. Just like philosophical laws go, there's always spiral in development. So we started with non-rechargeable devices and radio frequency receivers. We moved away from them toward rechargeable technology. And now we're going back to what's called recharge-free, which is the same prime cell devices we were using before, except they're much smaller and much smarter. So the batteries become much longer lasting. The smaller units are now fit within those titanium boxes. So now we made a full circle, and now we have recharge-free devices, which are more pleasant to the patient because they eliminate charging burden. So we don't worry about overheating the devices, irritation of the skin from the chargers, and so forth. And once again, it's nice to have options. These are most recent iterations, and there are many companies on the market. When I started, it was one, and now there's probably at least 10 neuromodulation companies, and it's great. We see it in exhibition hall, but we also see it in our operating room because now we can choose different options based on the patient's pathology. And you can see here you have small devices, rechargeable, recharge-free, with different paradigms, upgradable, with multiple configurations, and this is something that makes us happy. But it's not just generators that changed. The electrodes changed, and I'm sure you're familiar with this timeline when we started in 1970s and 1980s with single contact electrodes that had to be sutured in place to something that could be inserted with percutaneous or open surgery. And then as time goes on, the number of electrodes, the position of them, the size of the contacts, all of this changed. And just number of contacts went up logarithmically. So from 4 to 8, now we have 16 contact electrodes. That's for percutaneous inserted electrodes. Now in the paddle world, where most of surgeons operate, we started with 4 contacts, simple paddles, which we could not even plug into generator, had to have special extensions, to 8 contacts, 16 contacts, 20 contacts. Now we have 32 contact electrodes. And what's important about them? Oh, they have different number of columns. So you can put electrode with a single column to the side or to the center of the spinal canal. Or you can put one electrode with multiple columns trying to stimulate different parts of the spinal cord or to compensate for variability of physiological midline. Because not everything that we see on the X-ray correlates with physiology of the spinal cord. So it's nice to have multiple columns so you can steer within the same device without worry of losing or missing physiological midline and therefore losing all the benefits of stimulation. So from 1 to 2 to 3, now 5 column electrodes, that's a routine thing. The wide choice is what we show the patients. Pretty much every company has wide choice of electrodes, so we don't have to worry that we do not have paddles or we do not have percutaneous electrodes from one company or another. If we want certain stimulation paradigms, chances are you're going to have a device which is fit for this individual patient, kind of tailoring the surgical approach or interventional approach to this particular situation. The anchors. Remember those anchors that you had to suture multiple times just to hold them in place and make sure the anchor stays and the electrode stays within the anchor, and all of these issues that would be kind of balanced. Are you anchoring too tight so electrodes will break, or you not anchoring tight enough so electrode will migrate? So this continuous, tug, pull and push situation. That's changed because now we have locking anchors. We can do something that we can actually lock the anchor in place without destroying it, and that will significantly minimize amount of migrations. We actually have injectable anchors to minimize the profile, to lower the profile of intervention, to make it more intuitive. So you can get in, you can inject the anchor over the device, and it will hold it, because you can anchor the anchor to the tissue, but you don't have to worry about the electrode being held within the anchor itself. But it's not just that. The patient remote controls, you probably don't remember this, but there was a suitcase for a remote control when the first remote controls became available. So the patient would bring the suitcase to the clinic just so his remote control can be tested during the programming session. That's long gone. Now we have smaller remote controls that allow the patient to switch between programs. As a matter of fact, they are more colorful, they are more friendly, they're interfacing with devices. And that pretty much translated into everything else in terms of accessories, because the charging has become more fast, more intuitive, more interactive. The charging device can feel the proximity of the generator, can adjust the amount of current that travels through the patient's skin, can sense the temperature so that there's no overheating, there's no reactions. So for rechargeable devices, changing in the charging approach has been a major issue. The clinician programmers, I remember there was a suitcase for the patient carrying remote control, but there were two suitcases for me, one program stimulators and one to program the pumps. So that changed. The physician programmers become smaller. They also became nicer, so they have more options. The entire programming session became more intuitive, and that definitely easy things for us in terms of time, in terms of the productivity. The consumer technology-based, I remember when somebody was telling me about using a smartphone to program the stimulator, I thought it was very futuristic and unreal concept. But just like earlier speaker was talking about introduction of iPhones, this became reality. So now we have both iPhone and Android-based interfaces for our implanted devices, and patients love it. I mean, I have patients who uses his controller for the stimulator as a way to communicate with his family because he has great Wi-Fi connection. So things change. They adapt quite rapidly. As a matter of fact, now we have an option of remote programming, something that became available for deep brain stimulation maybe about 5 or 10 years ago with our Chinese partners. Now is a reality for everybody in the world because one of the biggest manufacturers has made remote programming a reality. So now we have this whatever brand name for that is, some sphere of sorts, when patients can be programmed from their home by a professional, the company representative, maybe some call center somewhere, but they can adjust the patient settings while maintaining visual contact with the patient and looking at their face and their behavior as you adjust the parameters. It became a major issue for our brain stimulation programming, and it's making its way into spinal cord stimulation arena. The procedural details, we're going in step with hardware advancement. So whatever we see in hardware progress had to be mirrored one way or another with procedures. But the procedure really did not change that much, interestingly enough. Because, we talk about percutaneous, open, intradural, extradural, and this, there's certain debates are still going on what is better. But the actual process has become perfected. So people learn this early on. They learn it during fellowships, they learn it during the initial years in practice, during their residency perhaps, and it's not a big deal anymore. I remember how difficult it was to convince people to start using stimulation because of technical issues. Not anymore, now it's a routine, now it's mundane. So percutaneous versus paddle, the debate is still ongoing. What's better, what's more stable, what migrates less, what stimulates better? When it all started, a major advantage of paddle was lower power consumption because, unidirectional stimulation. But that went away as rechargeable device became available because nobody worried about power consumption anymore. So percutaneous electrodes made their rebirth. But then there are certain other attributes of paddle that are important. For example, there's stability of the electrode. There's multi-column ability to stimulate the spinal cord with single insertion. There's the ability to decompress the spinal canal when you're implanting the paddle. So there's many advantages. But the argument is still there. What's better for the patient? Does everybody need laminectomy to have electrodes in place? Or in my practice, 90% of implants are percutaneous. But that changed because we now have percutaneous paddles. Now, very few people actually use them, but they do exist. So you can put percutaneous paddle into the spinal canal without doing laminectomy. So there's certain progress in the hardware in every direction, and I think it's important to be aware of this because we're moving along with it. Why it's important to have multiple columns? Just remember, when Sheely was putting his electrode, the electrode was stuck in the spinal cord, and every entire spinal cord was stimulated. This has changed because as we navigate through stimulation, we can guide our electricity towards part of the spinal cord. So when we do percutaneous trial, we can move the electrode and rely on the patient's response to see where we are. But if you want it on one side, it definitely works better when you have two electrodes because you can stimulate from one and ground to the other. That skews your field towards the area where stimulation is needed. But then there's nerve roots, and nerve roots don't want to be stimulated. They don't like that. They hurt. So you have tripolar stimulation. So you can shield the nerve roots, bilateral electrodes, and stimulate through the central one, trying to drive stimulation deeper into posterior columns. So that's where the back fibers are, that's where the food is. So all of these issues that we want to cover with more focused stimulation does better with tripolar stimulation. And having the paddle in epidural space makes it even easier because you have predetermined distance between different columns, and you can ground on the sides, and you can drive stimulation through the central column, non-structural columns, and get stimulation where it's needed, which is in the depth of the dorsal columns. So anatomy, physiology, hardware, and our thinking about this, they all merge, and the stimulation is becoming more intellectually driven. The indications to stimulation have progressed quite a bit. I remember when we started, it was for pain, a pain, some kind of pain, but pain nevertheless. But when we stimulate spinal cord, the spinal cord is very complex structure, right? So it has sensory pathways, it has motor pathways, it has a lot of autonomic pathways. So by doing this, you can address not only pain, but you can address motor dysfunction, you can address genitourinary symptoms, vascular symptoms. There's plenty of experience of using exactly the same hardware for treatment of peripheral vascular disease, coronary disease, and if you stimulate in the cervical spinal cord, you can get coverage of the cerebral problems, to treating migraines, treating post-stroke ischemia, treating arterial vasospasm. Those are potential indications. And it's growing, but growing slowly. So we don't see as much increase in that direction. But I think what's more probably fascinating is an ability to control motor dysfunction. So when this paper came out in Science more than 10 years ago about ability to control Parkinsonian symptom in an animal with a spinal cord stimulation, rather than putting stimulator in the brain, rather than actually entering the nerve brain tissue to put electrodes here, we're going through epidural, controlling the symptoms. That was groundbreaking. It got everybody's attention. But there was much less attention when the clinical paper came with the very same approach. So patients with chronic pain were implanted with spinal cord stimulation devices, and their Parkinsonian symptoms went away. So this is something we rarely use or talk about because it's completely off-label, but people are aware of this, and I'm sure it will change the way we approach this. So when you're an interventional physician, you may find patients coming not only for treatment of pain, but for treatment of any other conditions for whom your skills will be usable. So using spinal cord stimulation for control of tremor or control of slowness of movements, why not? I mean, the device is already there, the patients are definitely there, and when you have an alternative of having more or less invasive intervention wins. Paradigms. When Dr. Sheely started, or even before him, when people were trying to do electrical stimulation, they're very straightforward cycles of square waveforms at very regular cycles. So this is being debated until now. What's better, constant current or constant voltage? Constant voltage paradigms Very simple to administer. You have the same voltage coming through the device, independently of impedance, independently of resistance. It's the same amount of electricity that drives in. Constant current is slightly different. As impedance changes, the voltage adjusts itself to deliver the same current of electricity. So what's better? If you look at literature, there's as many things supporting one or the other approach. So I don't know who's going to win. If whoever publishes this usually has 70% towards their promoted modality. But there's no controversy here. It's essentially there's 25% who like constant current, there's 25% who like constant voltage, and there are 50% who don't care. And depending who sponsors the study, those 50% get attached to the area. So this is kind of ongoing discussion. But the neuromodulation does not stay at the spinal cord alone. We're going outside of spinal cord. So extraspinal stimulation within the spinal column, like when we stimulate the roots or the ganglia, or outside the spinal column when we stimulate the nerves, that's definitely becoming more acceptable. Remember, in 1967, before spinal cord stimulation, people stimulated peripheral nerves. The spinal cord stimulation became more predictable, and it took over the frequency and the incidence of interventions, and therefore the spinal cord stimulation has become the mainstream treatment for chronic pain. But peripheral nerve stimulation still exists, and we see more and more of it now with multiple companies coming out with approved equipment specifically for that. The hybrid stimulation, the concept that was very interesting, introduced about 20 years ago, is something that we have not explored completely yet. So maybe by stimulating multiple targets at once, we can get better results. And we can definitely individually tailor it for every patient because everybody's pain is slightly different. So there are candidates who are perfect for spinal cord stimulation. There are candidates who are perfect for peripheral nerve stimulation. But I'm sure there's plenty who would benefit most from having both modalities at once. The DRG stimulation was a very weird concept that was initially described in the 1970s when people would put electrodes into foramen and stimulate this obscure structure, something that we would normally remove during ganglionectomies. Suddenly they put stimulators and tried to stimulate them with a very narrow therapeutic window, didn't take much interest, has changed when the company became enthusiastic about it and created dedicated equipment. So we now have randomized prospective studies showing that DRG stimulation actually works and works well for very specific indications. People try to widen these indications, trying to use them in the cervical area, in the upper thoracic area, for a variety of things. And the progress is definitely ongoing. But we have become smarter. We definitely became safer. We know how to do this. But we still do not have any option for patients who already had surgery on this ganglion because we don't have DRG stimulation paddles. So maybe it will change. The high-frequency stimulation, you've heard of this. 14,000 hertz is what they started in 1962. Now we have 10,000 hertz devices who are stimulating spinal cord, and they are now commercially available, once again, as a result of prospective randomized study. 10,000 hertz, something that normally puts tissue to sleep, does not put spinal cord to sleep. It actually works on subperception level with very narrow pulse width, biphasic waves. Now we use them routinely. Some people like it, some don't, but it exists, and it has more and more documented evidence showing the support of technology in different indications. Another concept of having stimulation instead of coming continuously, delivered in bursts, kind of taking example from physiology of the human brain, when very little information is being transmitted in tonic fashion, actually probably none is transmitted tonically. Everything that we have to do in the level of thalamus does come in bursts. And we know this from recordings from the brain whenever we do tremor surgery or anything else on the brain level. We see those bursts, and those bursting cells, they're definitely much more effective in transmitting the information. So our colleague, Dr. De Reeder, came this to the practical realm and created this burst stimulation that we are now using for spinal cord stimulation indications. So this has changed the way we're doing this. The burst comes in very narrow set of stimulus, 5 shots at once, within a very short period of time with a wide interval between them. That seems to work quite well. Interestingly enough, in addition to conventional ways, it seems to work through very different pathways inside the nervous system. So when we talk about stimulation of lateral versus medial pathways, there's actually imaging evidence of this happening. So we can stimulate not only somatic perception of pain that goes through the lateral pathways, but we can stimulate the emotional perception of pain that goes towards the limbic system. Because if we can control the emotional part of pain, then first of all, we can help patients significantly better. And on top of that, we can actually offer help to patients who would normally be screened away from stimulation. Because everybody with depression, everybody with psychological overlay on their pain probably would benefit from burst stimulation more than they would do from conventional. Because activating medial system probably will make sense for some of these patients with or without lateral system activation. The concepts are changing continuously. Now we have multiple proprietary paradigms, but just simple one like high-density stimulation that was introduced by one of the companies recently showed that when you stimulate everybody the same way, the effects are kind of predictably lower the patient's pain initially, then the pain returns to some extent, and then whether you activate or not activate this new algorithm or new paradigm, you can see significant difference in the number of responders. So you got to be aware of all this because that changes how you approach the patients, it changes your expectations and your patient's expectations, maybe screens patients in and out, but ultimately it affects your practice. The miniaturization has made the progress into neuromodulation field. Now everything we fit in a large box of generator now can be squeezed to be put inside the electrode. So now you have this miniaturized kind of nanotechnology approach when you have the entire system within the electrode itself, making the entire approach much less invasive, making this technology available to both spinal and outside of spine applications. We'll see if that becomes mainstream at some point. So far it hasn't, but things are changing. We are living in a fluid environment. The entire concept of stimulating doesn't matter what, whether the patient moves or whether the patient breathes or whether the patient changes position, is fading away. We can actually now identify the biomarkers of the spinal cord stimulation response through this compound evoked potentials. And we can record these potentials from the same device. So as the patient moves or as the patient breathes and the potentials change, we can adjust the stimulation automatically. So this closed loop approach has been used for many different applications. I mean, we have pacemakers that turn themselves on when it's needed and defibrillators that only jump in when it's needed. So we can do the same thing for spinal cord stimulation technology. And this is just the beginning because it's a very primitive and simple approach, but there will be more. We're going to have non-invasive biomarkers that will adapt our stimulation. We're going to have some biochemical markers that will guide the paradigms that we use. And that's the direction we're all heading to. So I think the closed-loop stimulation is here to stay. We'll see how it affects our patients on real life. And I'm sure that every company will have their own closed-loop paradigms at some point. But the idea that we can adapt the stimulation based on individual parameters in real time, not just waiting for the patient to click the button, but the real-time adjustments, that's what will make a difference. The stimulation is now documented by a variety of different studies, and you can see a whole bunch of them. And Dr. Manchikanti was part of many of them, and so were you. And I think it's important to have this evidential base for our work because it's important to know that what we're using actually does work. It's not just our imagination. Now, the future, the key part. A few years ago, I was asked to write about the future of spinal cord stimulation. And I came up with this quote from Niels Bohr, which also is ascribed to Yogi Berra. It says, it's hard to do predictions, particularly about the future. So I think that's true. We don't know what's going to happen to us. But I can tell you the future of neuromodulation is bright. There's plenty of things we're going to do, and there's plenty of things that will change the way we approach it. So let me just go. I thought I had 6 more minutes. I'm sorry, I'm looking at this clock. So it says, and I'm not to stop. But I'll be quick. So what's the future of neuromodulation for pain? Extraspinal stimulation. Stimulate the spinal cord in this case probably will be a thing of the past. We already have these devices when we can stimulate paraspinal muscles, hoping that this will improve the patient's mobility and the strength, maybe eliminate need for surgery for some of them. You see more and more of this coming out in literature. And altogether, the invasive stimulation probably will go away because things will be non-invasive. We see that in the brain stimulation. All of these things to stimulate supraorbital or vagal nerves without cutting the skin, that stakes the ground. People are very excited about this because it's definitely attractive. No surgical complications because there's no surgery. As a matter of fact, I'm sure you're aware of this, but there is now a non-invasive device for treatment of pain. You just put the helmet on your head, and you have non-invasive, at-home stimulation to control the pain. The patient doesn't come to your office to have the TMS. They put the device at home, and they stimulate, and the pain is improving. The augmented reality, we use it for simulation now. Wouldn't it be nice to know what you're doing when you have not the fluoroscopy device that radiates you, but something that merges with the patient's preoperative imaging so you know where the electrode goes? The virtual reality, we use it now for surgical planning and neurosurgery. Maybe we can do the same thing for spine. Maybe we can know where to put our electrode and what kind of electrode or what kind of decompression device to use for this particular patient. The out-of-box thinking, I think that will be the real future for us. Because just think about it. We're using large incisions, we tunnel our wires. We may not need to do this. There are super miniaturized autonomous devices which are already available for the heart. You put a tiny electrode with a generator in it that stays in the heart, senses and stimulates at the same time. No tunneling, no wires, no large generators. Many companies are making them now. As pain specialists, we probably are not aware of this very much, but it exists and it makes its way to our field as well. Body heat power devices. Just think about it. We make energy all the time. Why not use it? 10 years ago, this became available for pacemakers, so hopefully we'll see it for neuromodulation devices as well. And I think one of the most interesting things is dissolvable hardware, because not everybody needs a generator for the rest of their life. You have now devices that can actually absorb over time on their own. So you can have this in terms of the stimulators. You can have this for sensors. All this bioabsorbable technology will make its way to our world. And on this, I want to finish, and I want to thank Dr. Machikandi for allowing me to do this. I think it's a great opportunity for us to discuss all this. I want to bring your attention to this WikiStim mechanism. It's a free search engine for anything that has to do with stimulation. And I want to thank you once again for having me here.